This training video will demonstrate the method used at Menlo Park Fire District for splinting and extremity injury. There are many acceptable methods for splinting, but having one method used by our personnel will eliminate confusion and streamline patient care. The first step is direct manual stabilization of the injury. If the injury involves a joint, the goal is to stabilize that joint. If the injury involves a long bone, you will want to stabilize the joint above and below the injury. Assess circulation, sensory, and motor functions distal to the injury. If using a pulse that might be hard to locate again, such as a pedal pulse, mark the location with a Sharpie or pen. In general, you want to immobilize the injury in the position that it is found, unless it is necessary to move the extremity for extrication, comfort, or there is an absence of CSM. If needed, slowly move the injured extremity in line to its normal anatomical position. Stop if you meet any resistance. Administer the appropriate pain management to the patient, such as fentanyl and ice packs, before movement and splinting if able. Splint the injury using a SAM splint, cardboard splint, or vacuum splint. No matter what method you use, make sure you will be able to assess CSM when done. Vacuum splints are a good option because they are fast, can form to the shape of the injury, and be left on during x-rays or other imaging methods at the hospital. First, make sure the beads are evenly dispersed within the splint. Form the splint around the extremity and hold it in place. It can be folded if needed. Using the vacuum hand pump, slowly remove air from the splint until it becomes rigid. Press the blue fill hose in to close it and secure it in place with tape. These are single use and can be restocked off the ambulance. For SAM splint, the goal is to bend the splint to fit the shape of the extremity while also having rigidity. The SAM splint is ineffective if it is not rigid before secured to the patient. Secure the SAM splint using Kerlix. Immobilize upper extremity injuries with an arm sling. There are also cardboard splints in the EMS cache that can be used to stabilize an injury. Make sure to pad around the extremity and secure the splint using strips of Kerlix. After any splints is applied, reassess circulation, sensory, and motor function. This should be reassessed throughout patient contact. Remember, splinting is important to reduce any additional injury, reduce pain to the patient, and to aid in extrication and movement. Although it should be addressed as soon as possible, do not let splinting interfere with any life-saving intervention or initiation of rapid transportation when indicated. If splinting cannot be accomplished within the Platinum 10 on major trauma patients, you can maintain manual stabilization of the injury and complete splinting while en route to the hospital. Thank you for watching. This concludes our review of splinting.